en los próximos 30 días. También importantes medidas en otros países, como en Bélgica, que imponen la cuarentena. Y a las 9 de la noche, hora local, aquí en España, se espera la comparecencia del rey Felipe VI.
Y aquí, en RT, hemos podido analizar esta crisis sanitaria con el doctor Germán Peces Barba, vicepresidente de la Sociedad Española de Neumología y Cirugía Torácica.
Ellos, 24 horas sobre 24, están a vuestra disposición. Más 34 91 394 8900. ¿Qué estamos haciendo para ayudaros? Porque yo sé que algunos de vosotros estáis esperando desde hace algunos días. Quiero pediros paciencia, quiero pediros colaboración y responsabilidad, porque así juntos vamos a poder ayudarnos los unos a los otros. En primer lugar, estamos en contacto con las líneas aéreas, con los proveedores de transporte para asegurarnos que se mantienen conexiones que os puedan devolver a España. En segundo lugar, estamos en contacto permanente con las autoridades de otros países de la Unión Europea y de países vecinos, desde Alemania, Francia, Reino Unido, Dinamarca, Irlanda, Suecia, para colaborar en ayudaros a retornar a Europa, a España. Estamos también coordinados con el Mecanismo de Protección Civil Europeo, que intenta para ayudaros a retornar.
Quand je fais comme ça, tu unmute.
Ok.
Merci, mon frère.
Good. Yes, we need to use. I know I don't take this, but you need to use mic when you speak. Good afternoon, everyone. Apologies for this delay. First, welcome everyone for this regular press conference on COVID-19. We are today in the executive boardroom of the World Health Organization, and this is basically to give us a little bit more space so we can all follow the good practice of physical distancing. We have our regular guest by now, Dr. Tedros, Director General, Dr. Maria Van Kerkhove, who is our technical lead for COVID-19 response, and Dr. Mike Ryan, Director of Emergencies. I understand that Dr. Tedros may leave at some point, but hopefully we will have questions for other guests. Before I give the floor to Dr. Tedros, just to remark that we had some issues, technical issues with sending media advisories. We had some meetings just a few hours ago, and hopefully this will be sorted, and everyone who is on our lists will be getting the notes from WHO, including media advisories, press releases, and all the other notifications. We will have an audio file as we always do, and hopefully a transcript will be available tomorrow. Dr. Tedros, please.
Thank you, Tariq. And good morning and good afternoon, everybody. It's now more than a month since the last case of Ebola in DRC. If it stays that way, the outbreak will be declared over in less than a month's time. We would like to thank all our partners for their solidarity in staying the course in the service of the people of DRC, and my special appreciation especially to the government and people of the Democratic Republic of Congo. That same spirit of solidarity must be at the center of our efforts to defeat COVID-19. More than 200,000 cases of COVID-19 have been reported to WHO, and more than 8,000 people have lost their lives. And more than 80% of all cases are from two regions, the Western Pacific and Europe. We know that many countries now face escalating epidemics and are feeling overwhelmed. We hear you. We know the tremendous difficulties you face and the enormous burden you're under. We understand the heart-wrenching choices you're having to make. We understand that different countries and communities are in different situations with different levels of transmission. Every day, WHO is talking to ministers of health, heads of states, health workers, hospital managers, industry leaders, CEOs, and more to help them prepare and prioritize according to their specific situation. Don't assume your community won't be affected. Prepare as if it will be. Don't assume you won't be infected. Prepare as if you will be. But there is hope. There are many things that all countries can do. Physical distancing measures like canceling sporting events, concerts, and other large gatherings can help to slow transmission of the virus. They can reduce the burden on the health system, and they can help to make epidemics manageable, allowing targeted and focused measures. But to suppress and control the epidemics, countries must isolate, test, treat, and trace. If they don't, transmission chains can continue at a low level, then resurge once physical distancing measures are lifted. WHO continues to recommend that isolating, testing, and treating every suspected case and tracing every contact must be the backbone of the response in every country. This is the best hope of preventing widespread community transmission. Most countries with sporadic cases or clusters of cases are still in the position to do this. Many countries are listening to our call and finding solutions to increase their ability to implement the full package of measures that have turned the tide in several countries. But we know that some countries are experiencing intense epidemics with extensive community transmission. We understand the effort required to suppress transmission in these situations, but it can be done. A month ago, the Republic of Korea was faced with accelerating community transmission, but it didn't surrender. It educated, empowered, and engaged communities. It developed an innovative testing strategy and expanded lab capacity. It rationed the use of masks. It did exhaustive contact tracing and testing in selected areas. And it isolated suspected cases in these designated facilities rather than hospitals or at home. As a result, cases have been declining for weeks. At the peak, there were more than 800 cases, and yesterday the report was only 90 cases. WHO is working in solidarity with other countries with community transmission to apply the lessons learned in Korea and elsewhere and adapt them to the local context. Likewise, WHO continues to recommend that wherever possible, confirmed mild cases should be isolated in health facilities where trained professionals can provide good medical care and prevent clinical progression and onward transmission. If that's not possible, countries can use community facilities to isolate and care for mild cases and refer them for specialized care quickly if needed. If health facilities are at risk of being overwhelmed, people with mild disease can be cared of or cared for at home. Although this is not the ideal situation, WHO has advice on our website for how home care can be provided as safely as possible. WHO continues to call on all countries to implement a comprehensive approach with the aim of slowing down transmission and flattening the curve. This approach is saving lives and buying time for the development of vaccines and treatments. As you know, the first vaccine trial has begun just 60 days after the genetic sequence of the virus was shared by China. This is an incredible achievement. We commend the researchers around the world who have come together to systematically evaluate experimental therapeutics. Multiple small trials with different methodologies may not give us the clear, strong evidence we need about which treatments help to save lives. WHO and its partners are therefore organizing a study in many countries in which some of these untested treatments are compared with each other. This large international study is designed to generate the robust data we need to show which treatments are the most effective. We have called this study the Solidarity Trial. The Solidarity Trial provides simplified procedures to enable even hospitals that have been overloaded to participate. Many countries have already confirmed that they will join the Solidarity Trial. And these countries are Argentina, Bahrain, Canada, France, Iran, Norway, South Africa, Spain, Switzerland, and Thailand. And I trust many more will join. I continue to be inspired by the many demonstrations of solidarity from all over the world. The COVID-19 Solidarity Response Fund has now raised more than $43 million from more than 173,000 individuals and organizations few days since we launched it. I would especially like to thank FIFA for its contribution of $10 million. This and other efforts give me hope that together we can and will prevail. This virus is presenting us with an unprecedented threat, but it's also an unprecedented opportunity to come together as one against a common enemy, an enemy against humanity. I thank you.
Thank you very much, Dr. Tedros, for these remarks. We will start with the questions. I will just remind once again, if it's possible, to have only one question per person, so we can get as many questions as possible. So if we are ready, we can start with Pavel from Poland, from the outlet
Hello,
Noise. Pavel, can you hear us?
Yeah, can you hear me? Hello? Hello?
Yes, we hear you. Go ahead, please, Pavel.
Okay, hello. Up to today, Poland ran 9,000 tests on a population of 38 million, which many consider as far too few. Do you have any recommendation on how much testing is advisable for a country in containment phase like Poland? And when can we expect cheaper version of diagnostic tests to be available in Europe? Thank you.
If I understood well, the question is about how much testing should be done in a country of the size of Poland?
Yes, yes.
And when the tests would be available in Poland?
No, when cheaper version of diagnostic tests be available in Europe.
When cheaper tests would be available in Europe?
Okay. First of all, the volume of testing is clearly determined by the number of suspect cases that you have. So I think the focus here is not how much testing it needs to be done to reach a certain number. The real challenge is, are you testing every single suspect case? Every suspect case should be tested, their contacts identified. If those contacts are sick or showing symptoms, they should be tested. That requires a scale up because many countries have not been systematically testing all suspect cases, and it's one of the reasons why we're behind in this epidemic. So we need that to happen. Secondly, there are many manufacturers producing tests. WHO is contracted with a manufacturer of production of tests mainly aimed at supporting developing countries. I am sure that Poland and through the European Union and others has access to many companies who are producing tests either in the academic or in the private sector. But if there is a need, any country may contact WHO and we will either point them to a manufacturer or, if needed, provide them with emergency testing capacities.
Thank you very much. Hope this answers question from Pavel. If we can go now to Simon Ateba from Today News Africa. Simon, can you hear us?
I can hear you. Can you hear me?
We will try to level up the sound a little bit. Please go ahead, Simon.
Go ahead. Okay, thank you for taking my question. My name is Simon Ateba from Today News Africa in Washington, D.C. I know that coronavirus is spreading in Africa, is now in over 30 countries, and almost 600 people have been affected. But there's a problem. You still have big gatherings. You still have big religious gatherings. You still have big weddings. For instance, a popular pastor in Nigeria, Prophet T.B. Joshua, has told his followers that the virus will be defeated on the 27th of March, and he's not the only one. So my question is, do you think this is the time to avoid, to stop big religious gatherings, big weddings, and all the things that bring us together in Africa and believe in science for the first time?
Thank you very much, Simon. The line was not the best, but I will just repeat the question for everyone. The question is about big religious gatherings in Africa, and is this a risky thing for spread of the virus on the continent?
First of all, congratulations to many of our member states in Africa who've reacted very quickly to put in place the necessary surveillance, the laboratory testing, and other measures. Africa is a resilient continent with a resilient population who've dealt with and deal with epidemics every day of every year, unfortunately. At the moment, the incidence of COVID-19 in Africa is low. It may be higher due to lack of detection, but within reason, Africa still has a major opportunity to avoid some of the worst impacts of the epidemic and to prepare its public health system and its health system for this. With this in mind, African countries are looking at all of the different options, and I'm sure they're looking at the experience in Asia, the experience in Europe, and looking at what options work best for them. Certainly at this moment in time, all countries that have disease inside their borders need to examine the appropriate measures to limit contact between individuals, particularly large mass gatherings that have the potential to amplify disease. But we fully understand that depending on where countries are in the disease development or in the evolution of the epidemic, those decisions are based on different risk management factors. But in principle, WHO's view at this moment is that all countries with community transmission or clusters of cases inside the country, in order to avoid disease amplification, should be seriously considering delaying or reducing mass gatherings that bring people together in an intense way and have the potential to amplify and spread disease, particularly large religious type gatherings that bring people from very far away into very close contact.
Yeah, maybe I'd like to add to what Mike said. You know, as of today, the number of cases reported from sub-Saharan Africa is 233 cases and 4 deaths. And it's actually, in terms of confirmed cases, it's the lowest region. But as Mike said, we cannot take this number as, you know, the amount of, or the number of cases we have in Africa. Probably we have undetected cases or unreported cases. But in addition to that, even if we take these 233 cases are true, we have to prepare for the worst. In other countries, we have seen how the virus actually accelerates after a certain tipping point. So the best advice for Africa is to prepare for the worst and prepare today. It's actually better, if these numbers are really true, to cut it from the bud. And that's why we're saying we have to do the testing, we have to do the contact tracing, we have to do the isolation, and cut it from the bud. And with regard to mass gathering and so on, it will help if we avoid that. And WHO's recommendation is actually mass gatherings should be avoided, and we should do all we can to cut it from the bud, expecting that the worst could happen, because we have seen how the virus really speeds up and accelerates in other continents or countries. So that's our advice, and I think Africa should wake up. My continent should wake up. Thank you.
Thank you very much, Dr. Tedros and Dr. Ryan. Let's try to get to Musa from Mayadeen. Musa, I understand. Musa, can you hear us?
Oui, je suis là. Alors, j'ai une petite question concernant l'Iran. Je vais demander comment l'impact des sanctions américaines a-t-il affecté la capacité de l'Iran à faire face à la propagation de cette épidémie? Et est-ce qu'il y a eu des contacts avec Washington pour réduire ces sanctions, en particulier sur le matériel médical? Si j'ai le droit d'une petite deuxième question.
Moussa, on va s'arrêter là. Je crois qu'on a dit une question par personne. Merci beaucoup.
OK, c'est bon.
Merci beaucoup, Moussa. So our friend Musa from Mayadeen is asking about the sanctions to Iran and how sanctions on Iran have impacted the capacity of the country to respond to this outbreak.
We've been working very closely with the authorities in Iran and with many, many countries around the world now who have worked with us to ensure that Iran gets the assistance and help that it needs. We've again said right the way through this epidemic that we want to avoid politicization of these events, and we thank those member states. And there are a wide range of member states from different political and different persuasions and ideologies who have agreed to act in solidarity together to support Iran's situation. And we're focused, as we have been, on providing lab supplies and reagents, in supplying PPE, and in ensuring that Iran has access to the markets it needs to do that. And we've been working at a very detailed level, not only through the sanctions, but through the banking system and others, to free up the necessary resources and to free up and provide the necessary assurances to companies and others that they can, with comfort and without fear of any consequence, supply Iran with essential medical equipment and supplies for the purposes of the control of COVID-19. The DG may wish to speak on some of his political engagements that have successfully ensured that this circumstance has come to pass. We are in solidarity with our brothers and sisters in Iran and all over the world, and will ensure that every citizen in every country has the opportunity to access global goods at this point in time.
No, thank you very much. The only thing I would like to add to that is we're already in contact with senior officials from Iran. I had spoken to the Minister of Health yesterday and also had a chance to speak to Secretary Pompeo yesterday. And we have underlined the need for solidarity. And I remind all of us of the statement that the United States, and especially Secretary Pompeo, issued some weeks ago. And we have discussed on how best that can be implemented. And as Mike said, some of the process, especially with banking and so on. But in emergency situations, the sanctions can be addressed. And this is already agreed from the U.S. side, and that's why we had the statement. And we hope that we will have the needed solidarity to fight this enemy together. At the same time, I would like to use this opportunity to thank the Crown Prince. He sent the second round of support to Iran the day before yesterday. 2 aircrafts chartered, shipping materials needed, and that's what we're calling for the whole world to. For the time, I think we're in the most important solution in fighting an enemy like this dangerous virus is solidarity. And we hope this spirit will continue.
Thank you very much, and really sorry, Musa. We'll try to take your second question next time. And just to say that we all miss our Geneva press corps. So speaking about, let's go to Jamie. We miss Jamie as well. Jamie, please go ahead and ask your question. One question.
Can you hear me, Tarek?
Yes, please go ahead.
Okay, great. Hi, this is Jamie from Associated Press. We're wondering why might the death rates across Europe be so variable? Italy's death rate is at about 11%, and they will soon overtake Hubei province in terms of numbers of deaths, while other countries like Germany, France, Spain, and the UK have reported far lower death rates, closer to 1 to 2%. What might explain that discrepancy? Thanks.
Hi, Jamie. Yeah, I almost miss you as well. It's a good question, and there are a number of factors that might explain that. But certainly, one of them is testing. If you look at Germany, and we had some very good communication with Germany today. They've had a very aggressive testing process. They've tested and confirmed over 6,000 cases with just 13 deaths, but that may reflect the fact that they're really aggressive in their testing strategy. So the number of tests and the number of confirmed cases may be detecting more mild cases as a proportion of all cases. That's an important determination. The second issue is the evolution, or the time of evolution in the outbreak. What we do see is a pattern of long hospital admission. So Italy, having experienced the first wave of major transmission much earlier than other European countries, is now experiencing those deaths because a lot of people reach a point where they can no longer be saved in the clinical system. So therefore the deaths occur sometimes 2 to 3 to 4 weeks after the infection starts. So again, you have to look at where each country is in the epidemic cycle. The other factor may be to do with the age profile of populations. For example, Italy has a much older age profile and has a higher proportion of people in the very elderly category. And in some ways, Italy has been a poster child for healthy people living into old age. And we've always asked ourselves the question, why Italians and people living on the Mediterranean are healthier and live longer lives. But unfortunately, in this case, having that older population may mean that the fatality rate appears higher because of the actual age distribution of the population underneath. There may be technical reasons as well in terms of the ability to provide standard of care. We saw this in China. We saw this in Hubei. When you looked at the case fatalities inside Hubei and outside Hubei, there were significant differences in case fatality. And anyone who's ever worked in the front line of an emergency, when patient numbers begin to overwhelm, it becomes a simple factor of your ability to provide adequate care and react to every change in the patient's condition in an intensive care environment. So I think there are circumstances in which the standard of care cannot be maintained when patients are being overwhelmed. And I point you to the tremendously courageous and brave physicians, nurses and intensivists in Italy who haven't been dealing with 1 or 2 patients in intensive care. But for example, in northern Italy, over 1,200 patients in intensive care at the same time. It's an astonishing number. The fact that they're saving so many is a miracle in itself. So I think there are many factors, Jamie, and they all play into the actual numbers. Maria may offer more technical advice on that.
I think the only thing to add is exactly where the virus is circulating in each country. And so you have to look at the demographics of where it is circulating. In Korea, we had these clusters, these very large clusters related to a church, and the age distribution of those cases were much younger than what we're seeing in northern Italy, for example. You may see outbreaks in long-term care facilities where the age is much higher. And so it's important where those clusters are occurring and where you're capturing your cases from. But we do need to be very careful when we look at mortality rates and we compare mortality rates. It's not right to compare them yet. What we need to do is find out why we're seeing differences and what that actually means in terms of our understanding of this virus and how it impacts different populations. We've said previously that we need to be very careful when we compare a calculation of the number of deaths over the number of cases that are reported per country. And Mike has outlined the reasons why that is difficult. But we have not seen the way this virus will behave in other vulnerable populations. We have not seen how this virus will behave if and when we see in vulnerable populations of high prevalence of HIV, for example, or malnutrition children, for example. And that's what we need to prepare for. So every death is significant regardless of where this takes place, and we need to ensure that all of the measures that we take are preventing transmission, because every step that we take there will prevent death.
Supplement here on the issue of severity. If you look at the case series that are produced and published from Korea, almost 20% of their deaths have occurred in people under 60. So the idea that this is purely a disease that causes death in older people, we need to be very, very careful with. And physicians, again, in Italy will attest to this, and in Korea. This isn't just a disease of the elderly. There is no question that younger, healthier people experience a much overall less severe disease, but a significant number of otherwise healthy adults can develop a more severe form of the disease. And that's why we need to be ever vigilant in ensuring that we observe everyone, even the mild cases, for any signs of clinical progression to a more serious disease.
Thank you very much. We go for next question. That would be Diego from Brazil. Diego, can you hear us?
Yes, I can. Can you hear me?
Yes, please go ahead.
Yes, there's been a lot of speculation about cases regarding children. So if you could please clarify what is the data right now about the symptoms on children and how fast they can spread, the virus can spread on children.
Thank you, Diego.
So I can start with that. So yes, we know that children are susceptible to infection. We know that children are infected with this virus. But in terms of the reporting of cases across a large number of countries now where we have data, the number of cases, of reported cases in children is lower than adults. We know that children can have develop disease, and the disease that they develop in terms of the signs and the symptoms are similar to what we're seeing in adults, which include fever, which include dry cough, which include fatigue and muscle pain. Overall, the majority of children that are infected will experience mild disease, but that is not universal. There's a recent study that came out in China that showed that a number of children have developed severe disease and critical disease, and in China, one child has died. And so what we need to prepare for is the possibility that children can also experience severe disease. But the evidence so far is that children have mild disease. And only one death reported in China so far.
Thank you very much, Dr. Van Kerkhove. We will take one question from journalists who are, for some reason, unable to get on the line. So here's Camilla Hodgson from Financial Times asking, is there a shortage of tests and or test processing centers in Europe? Is that a reason that more testing isn't being done in countries like the United Kingdom?
I think countries in Europe have been scaling up their capacity to do testing over the last number of weeks. There are different options for countries. One is, lab testing kits, which do a small number of tests per kit. The other are automated machines that allow you to test a number of samples at one time. And then there are high throughput machines that allow up to 5,000 samples to be processed per day. And many European countries are moving through to put in place those more high throughput mechanisms to be able to test more and more cases. So yes, I think there's a scale up going on in testing, but I don't believe that the ability to test has been the reason for the not testing. I don't think that's been the limitation. I think it comes down to what the strategy of an individual country is. If you're going to make an attempt to detect every suspect case and test every suspect case, then I believe countries in Europe do have the capacity to do that. The tough part is then when you get those cases, being able to identify contacts and follow those contacts and quarantine contacts. Then you need to leverage a much larger public health response that comes in behind that lab testing and allows you then to suppress the virus through those individual isolation mechanisms. Isolating individuals or quarantining contacts is about removing people who are potentially infectious from the community. What in balance with that and in line with that, social distancing or physical distancing measures, in a sense, ask everybody to separate themselves from everybody else on the basis that we're not quite sure where the virus is. A combination of those two allows you to really suppress the virus. If you really focus on individual measures to try and take people who are known to have the virus or could have the virus out of the general population for a period of time, and at the same time you create some physical separation at the population level, those two combined can be very effective at suppressing transmission of the virus. In order for that strategy to work, you must have the capacity to do more extensive lab testing as you really try to search for and identify all of those suspect cases. And countries are coming up with different strategies to meet the testing demands, and maybe Maria can explain a little more on what those strategies are.
Yeah, so there's three major areas in which countries are working on to increase their testing capacity. The first is the kits themselves that Mike has described. The sheer number of available tests and companies that are developing tests and countries that have developed tests is incredible, considering we're 12 weeks into this outbreak, this pandemic. The second area is increasing the number of labs that can actually run these tests. So in every country, there are national labs that can do PCR. They're building on a flu, national influenza system that has been in existence for decades. But increasing the number of labs that can actually run those tests is an important part of the strategy. Whether you're using public health labs or you're using private labs or academic labs, whatever it may be, the number of labs that can do those tests needs to be increased. And the third area is the number of people, the workforce, who are actually going to run these tests. So this three-pronged approach of being able to have more labs that can do these, run these assays, more people who can run this, and have more tests available are really critical. We've also seen, and the DG gave a good example in Korea, where countries, not only in Korea, but countries are finding innovative ways to test people. So finding individuals, how can we run these tests? We saw this drive-through system, for example. But countries need to be creative in the way, use the fundamentals of public health in terms of tackling this virus, but think of innovative ways and creative ways in which you can find people that fit your transmission scenario.
Thank you very much. Let's go to next question. Helen Branswell. Helen.
Hi, thanks for taking my question. I was hoping you could give us some more information about the Solidarity trial. Could you please tell us what drugs have been prioritized?
Hi, Helen. Anna Maria Henao Restrepo will join us to give you the specifics on the trial. But it's a multi-arm trial, and countries are able to choose between any one, I think, or more of 5 therapeutics that are currently being evaluated, but it may be more. So Anna Maria will speak to this and give you the detail.
Good afternoon, Helen. It's an adaptive design. Initially, we have 5 arms. The first arm is the standard of care, the usual care that is provided to the patients in the country. The second arm is remdesivir. The third arm is lopinavir, rotinavir. The fourth arm is lopinavir, rotinavir with interferon beta. And the fifth arm includes chloroquine. The good thing about the trial is, as Mike indicated, that the randomization could be adjusted to the drugs available in each individual hospital over time. The other good thing about the adaptive design is that we can include additional arms or drop arms as our Global Data Safety Monitoring Committee advises we should do. Finally, Dr. Tedros mentioned that this is a very simple trial, and we think that it's very important that other research goes on that will contribute to our understanding of this disease, but this trial focuses on the key priority questions for public health. Does any of these drugs reduce the mortality? Does any of these drugs reduce the time a patient is in hospital? And whether or not the patients receiving any of the drugs needed ventilation or intensive care unit.
Thank you very much, Dr. Henao. If needed, we will provide the exact title of Dr. Henao. But now we will go to next question, to South Africa. We have Stephen from Hot 919. Stephen, can you hear us?
Yes, I can. Thank you very much for taking my question. I was going to ask about the Solidarity trial.
Stephen, we don't hear you very well. Can you speak a little bit?
I can. You're right. How's that?
It's a little bit better.
I wanted to. Yeah, okay. I wanted to ask, we've seen some schizophrenic government activity. I have to say, looking at the way our government here in South Africa has responded, I have been fairly impressed as a journalist and the response that the government has given. Is it an important factor for the government to be unified on this. Our opposition politicians have come out and said they're supporting government. We seem to be on the same page. I don't know what sort of interaction the WHO has had with South Africa, and maybe you are the people at the top and you're not to the day-to-day interaction. But in terms of the communications and our South African response, I'd like to get an insight from you as to your impressions.
Again, as the Director General has said many times, an all-of-government approach is absolutely underpins success in fighting any emergency, but in this particular case, all the more. So I think that has been the case in many countries, including South Africa. Another point to make here is that African countries have been dealing with emergencies, climate disasters, natural disasters, epidemics for a very long time. South Africa has had to deal with a terrible HIV epidemic over many, many decades. So the ability to create coherent responses to what are biologic threats is not easy for government, because these are threats you can't see and sometimes can't quantify. So having been through that kind of a crisis already prepares government for that leadership role when the time comes. Building trust with communities is tough at a time when many citizens have lost faith in government and all around the world. This is not easy. This is both an opportunity for governments to rebuild trust with their citizens, to rebuild that confidence that's needed to manage adversity, and to reach out and create a non-partisan, all-of-government, all-of-society approach to dealing with disease. But again, the idea here, and I say this with caution, many countries in sub-Saharan Africa, there are many countries in the world that have fragile health systems. That is correct. But they're not helpless. And I have worked with and in African colleagues and in Africa for many, many years. And what I see is a story of resilience, a story of coping, and an ability to overcome adversity through communities by building on community intervention, building on community acceptance. If we can match community participation with good governance, then I believe that Africa can succeed. It has demonstrated that time and time again. But it does require strong, united governance to deliver for citizens. And I think we're seeing that in Africa, and I hope we continue to do so.
Thank you very much. Dr. Tedros, as you can see, has left, but I'm sure our speakers will be able to answer one or two more questions. Let's go to Emma Farge from Reuters. Emma, can you hear us?
I can hear you. Hopefully you can hear me. I had a question about the strategy for the supply crunch. Do you think that the only way to meet the demand for equipment such as ventilators and PPEs is for non-medical factories to be retooled to make this sort of equipment? And are you calling for that on a large scale? Thank you.
You are correct. There is a real pressure in the market for personal protective equipment, for essential medical supplies, for providing care for people. Most countries are still in reasonable shape, but there are great disruption and there's great distortion in the market, and many would characterize that as a market failure. We're working very, very closely with governments, and in particular with our colleagues in the United Nations system, with the World Food Programme, who are working extremely closely with us. In fact, we have World Food Programme staff here with us, no better logistics organisation in the whole world in terms of supply chain management. We're working with UNICEF, we're working with other agencies in order to maximise our ability to access those materials on the global market. We also have some fantastic support from governments in trying to prioritise supplies for us so we can provide them to all countries the most basic needs, China being the lead in driving that approach of prioritising our supply chains in order to do that. There is a scramble on the market, and we do need order and discipline in that, and I do believe that institutions like the European Union and others are trying very hard to bring that order and coherence to the process of procurement and ordering and prioritisation. It's like any rush, and we've seen this in the supermarkets and the shops. If everybody rushes to to buy everything they think they need for the foreseeable future, then many people lose out. That is the same if it's toilet roll or if it's personal protective equipment. But, you know, we can afford maybe to run out of toilet roll, but health workers can't afford to run out of PPE. And it is a huge responsibility for governments around the world to ensure that not only their health workers, but all health workers have a fair opportunity to access PPE. That is a responsibility of industry, that is a responsibility of governments, that is a responsibility of the UN system. We're trying to do our bit, working very hard across the UN to make that an easy process for governments. Governments who wish to prioritise giving help to others can use WHO, use the UN platforms to do that. I know they're very busy and may not be able to do that themselves, but we would welcome any contributions, donations to an international system to supply PPE to those most in need, and in addition other essential supplies like oxygen concentrators and the rest. In terms of, we've seen some positive moves. For example, some countries in Asia are really looking at self-production of PPE. And we do, again, look, and again, there are some companies around the world, part of our pandemic supply chain network, who are actively working to license their production capacities to local producers for masks, for PPE, in order to be able to produce that at local level. That's a fantastic development, to transfer technology, license that, so that local manufacturers can come into the game. Ventilators and other sophisticated equipment is another scale of production and another scale of safety and ISO standards that are needed to meet that. We have to be very, very careful in scaling up production of sophisticated technology like that. But countries like China and others have immense capacities for ramping up production, and we're working with them to see how that can be achieved, and with other large-scale producers of such equipment. Ria?
Yeah, if I could supplement that. So in addition to everything that Mike said, it's important that every individual knows what their role is into ensuring that the supply that is needed is being used for in the most appropriate way. So what countries are doing in terms of what is their strategy for dealing with mild patients? What is their strategy for dealing with severe patients? Individuals need to know what their role is in terms of how they can prevent overburdening a health system. For example, if you're feeling unwell, you generally stay home. You don't rush to a healthcare facility. You contact either the hotline number that is available in your country, or you call your healthcare provider and you say, these are my symptoms, do I need to come in? And in most cases, you will not need to go in, you will not need. But if you do have the symptoms that we worry about for COVID-19, which include fever, which include dry cough, which include shortness of breath, then you will need to seek care. And so it's important that that process is in place in countries so people that they know where they can go and when they should go seek health care. It's about the rational use of masks. We have provided guidance about using a medical mask in the community. And if you're not sick, you shouldn't be wearing a medical mask. But if you are, then you should. Those decisions that are being